Welcome to Behind Beliefs, Behaviors, and the Brain, your communication podcast, where we bring brain science and communication strategy together to transform how we lead, connect, and thrive. I am your host, Dr. Maisha Claiborne, mom, physician, coach, consultant, and lover of all things brain and behavior. I also happen to be a trained expert in cultivating trust and safety through trauma-informed communication. Now, you may be wondering, what the heck does that mean? No worries. On this podcast, you will come to understand it all. Together each Monday, we will explore and uncover what drives our beliefs, shapes our behaviors, and influences our communication, from individual relationships to organizational culture. Each week, we dive into the science behind trust and safety, relating, communicating, and breaking through limiting beliefs that hold us back. So listen up, because whether you're a leader, a parent, a spouse, or just some amazing individual trying to get the tips for operating in your highest self, on this podcast, you'll learn how to harness the power of the brain to create real change in your relationships, your leadership, and your life. Tune in every Monday morning, and remember to subscribe so you never miss an episode. Now let's dive in and start reshaping communication from the inside out. It's time to transform one conversation at a time. Welcome back to another episode, and I am super excited because I have a repeat guest, and y'all know I love me some repeat guests. Whenever I have an amazing conversation, you all often hear me say that, oh, we need a part two. And while some people, may say that just, for kicks and giggles, I'm serious. And so I have here with me Dr. Sadaf Lodhi, and she was with me. We had an amazing conversation that by the time you hear this podcast, you would have heard this first conversation. And today we are talking about reproductive justice. We're talking about some disparities in women's health. And I'm just very excited. Dr. Lodhi is the owner of drsadaf.com, and she has a new practice. Remind me of the name of that practice, Dr. Sadaf.
Yes. FemV Health. It's in New York.
FemV Health in New York. And so we're going to be talking a little bit about what it is that you do. But first, I want to get the audience, anyone who may not be familiar with you. And if you're new to the podcast, you need to go back and listen to our first episode because it was dope. So tell us a little bit about you and what you do, and so that we can get to know you.
All right. Well, thank you so much for having me on and having me on as a repeat. So I am super lucky to have that time and space with you again. So thank you so much. So I'm a board certified OBGYN. I am also what they call an ISHWSH fellow. So ISHWSH stands for the International Society for the Study of Women's Sexual Health. So I focus on sexual medicine. And also I am a Menopause Society certified practitioner, as well as a coach. So I did coaching through Rutgers University. So I do all of those things.
Very cool. Very, very, very cool. Well, it's a lot of credentials, a lot of expertise. And I love that you focus on sexual health because, as we talked about in our last episode, this is something it's underappreciated as a specialty. And there are a lot of beliefs and a lot of thought processes around it. A lot of, what is the word that I want to use? Stigma.
Yeah. And stigma, taboo. Mm-hmm.
Taboo around it. And so again, if you haven't listened to that episode, y'all go listen to that episode because it was a really, really good conversation. But let's talk a little bit about reproductive justice, because that's how we came to this. Is we started that conversation. I was like, ooh, part two. So tell us, for those who don't know, what does that mean, reproductive justice?
Yeah. So basically, reproductive justice is the ability for every woman to have access to healthcare, such as reproductive healthcare, right? So the right for a woman to have children, not to have children, for her to be able to make that decision on her own. That is in itself is, the women exhibiting their own autonomy over their own bodies, right? And so we have a huge issue with that right now with Roe v. Wade, and most states, a lot of states, making it much, much more difficult for women to have access to reproductive health care, and a lot of women becoming reproductive refugees. And that's what we had talked, I think, a little bit about before, in that, women that are not able to access, say, abortion care, or even if their life is in danger, and they have to go to a different state. So I know that we have women coming from different states in the South up to New York to get reproductive health care because it's not allowed in their states. And we know that OBGYNs will get fined, they'll get arrested, their licenses can be taken away if they, participate in an abortion. And even if that woman's life is in danger. And I think even just this past week, we're recording right now in the late spring, and I think Florida is just about passing a very strict law that bans abortions at 6 weeks of age. So I think that really causes a lot of problems for women in terms of access to reproductive health care, and women may not even know their options. And so that's kind of, the right to nurture their children, and also to have a safe and a healthy living environment. So that's really reproductive justice in a nutshell.
I appreciate that. I think that's so important. And, one of the big reasons why we see health disparities in women's health is because of access to care and rights and things of that nature, certain laws, and they impact women of color, and particularly Black women. And we can see that in Black maternal health numbers and Black maternal mortality rates. And so, where there is a lot of very much needed focus in that realm of maternal morbidity, mortality, of access to abortion care, pregnancy care in general. One of the things that's not often addressed is what happens after that time. You're a menopause specialist, and it may be something that kind of is under the radar, but there are disparities in being able to have the quality of care, even as women age into menopause. And, I want you to kind of explain a little bit about the impact that menopause has on our systems as women, and why it's important that as we age, we get proper menopausal care, just as well as in the childbearing age, women get access to care for those things as well.
Absolutely. You're speaking my language here. So, it is, well, first and foremost, right? So not only do women have a hard time accessing reproductive health care, as you just mentioned, but women have a hard time accessing care as we transition into the menopause phase. And, not only do women have a hard time, but they often get dismissed. Their symptoms are, not believed by their practitioners, especially if they have, and nothing against male practitioners, but men just do not go through menopause, right? The way that women go through menopause. And so they just don't know. And, we have this arbitrary age that we say that most women go through menopause, which is the age of 51. However, we know that, not all women are, women are not a monolith, right? Not everyone experiences the same things at the same time. So we know that some women can have perimenopausal symptoms much earlier, and some women can have it later, and some women can have it for a prolonged period of time. As it turns out, there was an article that was published in 2002 by Harlow et al. That mentioned disparities, racial disparities in perimenopause and menopause, and specifically talking about African-American women and how these women actually tend to go through perimenopause starting earlier and for a longer period of time. And the thought is that because African-American women tend to deal with racism and systemic racism throughout their whole lives, that they are constantly subjected to stress. And so that stress increases cortisol levels, which then can actually change the DNA of women. And we see that because their telomeres, which are the ends of the DNAs, are actually shorter. By that, and that's a system of science, or it's a science healthcare field known as epigenetics. And basically what that says is how, the systemic racism is changing the DNA. And it's actually people that have experienced trauma can also experience the same things. And by having our DNA actually changing, it makes us more at risk for developing things such as high blood pressure, diabetes, high cholesterol, cardiovascular disease, all of those things, right? So we are almost predisposed to having those because our DNA has changed due to chronic stress. So specifically when we're talking about African American women, we know via the SWAN study, which is a multi-center study that was started in 1994 and looked at women across generations, really, and seeing how they experienced midlife transition. And they looked at women of different ethnicities. And what they noted was African American women tended to go through perimenopause earlier. So let's say that the mean age for somebody to go through perimenopause, because we know that menopause, if we're saying, was age 51, and the mean age for somebody to go through perimenopause, so the time right before menopause, is 7 years. African American women actually go through it for 10 years. Right. So they're starting, let's say, at the age of 41, whereas other women may be starting not until the age of 44. And so when they go and they speak with their practitioners and they speak with their, whoever it is, family docs, OBs, whoever, and they tell them that, hey, listen, I'm having these hot flashes, these night sweats, perhaps some brain fog, perhaps some arrhythmias, maybe some joint pain, maybe all of these different things that can happen in perimenopause, right? Maybe new onset anxiety, new onset depression. And they go ask for help for these symptoms. Their practitioners may not be well versed, one, in menopause, two, knowing and understanding that these women may be starting perimenopause much earlier. And then instead of giving them, let's say, hormones, which could really help stabilize what's going on, let's say they give them an antidepressant, right? There's nothing wrong with antidepressants, but if that's really not the root cause of your problem, it's probably not going to help you as well as, let's say, giving you menopause hormone therapy, right? Would. And so why this is super, super important. And I think that, the women listening to your podcast would be well versed just to kind of learn about their own ethnicity and find out, what we know about, say, African American women, Hispanic women, Asian women. We know that Hispanic women experience perimenopausal symptoms for about 8.9 years. Asian women are around 5 years. Caucasian women are 7 years. So just kind of having that breakdown and that time frame, women will know to make sure they go and they advocate for themselves, right? If they're being dismissed by their practitioner and the practitioner is saying, no, you're too young to be going through perimenopause, they can say, well, no, actually, you know what? I know that me being an African-American woman or the woman of color, can experience it much earlier. And what's really interesting is that I also read that, let's say, a woman who lives in Africa, who's African American, but who is in Africa, they have the same life expectancy and the same, let's say, risk for developing diabetes and high blood pressure as Caucasian women here in the US, because they are not being exposed to systemic racism day in and day out. Whereas when those women from Africa come to the US, by the time that they go through one or two generations, now their genetics have all changed. And now they're much higher risk for developing high blood pressure, for developing diabetes, because of their exposure to constant systemic racism. So it's really interesting. And like I said, you can look this up in epigenetics and what that has to say about our race and how we develop diseases. Because, I know that when I was going through med school, right, one of the risk factors for preterm labor was being African American. One of the risks for developing high blood pressure was African American. And nobody stopped. At that time, I was young. I didn't really know and understand that much as I do now. But nobody really took the time to say, wait a second, why is being African American a risk factor? Right? It's not that you're Black, that you're a risk factor. It's because of the things that have happened to you, that have changed your DNA, that have changed your telomeres, that have made you, right, be at risk for developing these. And why is that? It's because of the systemic racism that you exhibit day in and day out, that your cortisol goes up, that your DNA changes. And now that's why you're at risk, not just because you're Black.
Right. Yeah, and I appreciate that, especially the studies that have been done. And it's interesting because when I was in clinical practice and patients would come to me, when I was in clinical practice, I was one of the few people who entertained hormone replacement therapy. And I had to, I did lots of extra training in order to learn about it, to learn about the body, to learn about the differences and when the hormones begin to change and what hormone
Yes.
drops when, and like all of that, right?
Right.
And it would be very interesting to have patients come in, women come in and say, well, number one, either they would say, well, I think I'm going through menopause and I went to my OBGYN doctor and they say, well, you know, there's nothing we can do. You just got to go through it.
Yep.
Right.
Exactly.
Or if it seemed a little bit earlier for them, they would say that exact thing. Well, you're too young to be going through menopause. It's something else. And so, just having experienced that and being able to reassure the woman, like, no, you're not crazy, because that's basically what medical gaslighting is.
Right.
And there's a lot of medical gaslighting that goes on, particularly of women, in trying to advocate for one's healthcare. So I appreciate this knowledge because they can go into their doctor's office empowered and say, listen, I know that this study said that,
Yeah. Absolutely. And I think it's so important for us to validate women and to let them know that they aren't crazy and that there are therapies for them and that you can actually, transdermal estrogen. And, we haven't really talked so much about hormonal therapy, but we know that transdermal estrogen is very safe for women, even for women that have high blood pressure. Hopefully it's controlled, but women can even go on estrogen therapy as long as it's transdermal, because we know that if it's oral, if it's going through the liver, then it can impact the
Right.
blood pressure. But as long as it's through the skin and it's a patch, then it's a little bit safer, and even safe for women that have high blood pressure. I was just talking to a friend of mine today, and I was saying how learning about menopausal hormonal therapy is almost like throwing out everything that I know about using oral contraception out the window, because the risk factors, right, that we would say that, if you have high blood pressure, you can't take hormonal therapy. And I think all of that is because, one, it's not going through the liver, but two, because menopausal hormonal therapy is actually, the dosage that you're getting is way less than what you were even getting in contraception. And
Yeah.
that's why it's not as risky. Definitely there are some contraindications, and this is not medical advice. So definitely go see your healthcare provider before you get any type
That
of
part.
medication. But, for the most part, it is pretty safe. And if people are looking for, bioidenticals, we know that estradiol is the same. The patch, the one that comes in the patch, is the same as the one that's made in the body. That's the most common form of estrogen that we have in our body. And the micronized progesterone that we tell women to take orally if they have a uterus, along with the estrogen, that is the same form of progesterone that we have. And so they're the quote unquote bioidenticals, and you don't really need to go to a compounding pharmacy to get these medications. These are FDA approved, and you can get them from your pharmacy.
I want to talk a little bit about, I appreciate that. I love that information. And I want to talk a little bit about when a woman goes into an office to advocate for herself, because I think this is important, how to approach it in a way that the doc can hear, and what to do if, no matter how you approach, you feel like you're being gaslighted. So what I say is what I used to say to my patients is, if you go to a practitioner, whether it's a specialist, OBGYN specialist, whether it's an endocrinologist, whether it's a gastroenterologist, wherever you go, and you're asking for them to consider something, they're completely blowing you off, it may be time for you to get another practitioner, another physician, or another. So what are some of the ways, though, that patients can ask their doctor in a way that would feel, I hate to use the word less threatening, what I'm going to say, that would have the doctor most likely hear them?
Yeah, yeah. I think that if, a patient goes to their doctor's office and lets them know about their symptoms and then asks for their suggestion, right? Just saying like, these are the things that I'm going through. And I'd love to hear what your thoughts are as to why I might be having these symptoms. I've heard that, I could be perimenopause. Do you think it could be menopause, perimenopause? And what are the thoughts? I think maybe just approaching it that way, like asking your physician what are their thoughts and letting them know what your symptoms are. And then even telling them that, I think it's perimenopause, that what I'm experiencing. I know that it can be anywhere, even from my late 30s up until, my mid 50s, that I could be having these symptoms, right? And different women experience it differently. So, I'd love to hear what your thoughts are. This is what I'm thinking, can you help me out? Maybe in that more like conversation, and maybe like, maybe we can come up with a plan together so that, we're both involved in my care, because I'd love to have your input and your knowledge.
Yeah, yeah. I think that, and I would add to that, at least from my end, I have been doing a little reading on this, and I want to know your thoughts on this. This is something I read in this journal, not off
Yep.
of a thread necessarily, or this is,
Yeah.
I heard an OBGYN on a podcast talk about this. Because when you start to drop things like, journals and OBGYN, other OBGYN or other experts,
Yeah.
then they're more likely to perk their ears up and say, oh, maybe there's something I haven't read yet. Maybe
Yes.
there's something that I need to. And so I think that adding that language in,
Yeah.
especially if you are a woman of color or a Black woman, saying, well, I've been doing a little research. I read in this journal, and I heard, if you heard it on this podcast,
That's
and I
right.
heard on a
That's right.
podcast for an OBGYN who is an expert in hormone sharing, that that menopause could occur from this to this, and this is what I think it is. I'd love to hear your thoughts about that and how you could potentially help me out. And this is what I think should happen. Either the doc should say, yes, you know what, you're right. This is what we can do. Or they may say, you know what, you could be right, but this is not my area of expertise. Let me refer you to someone who can. Right? Those are the responses that let you know that their ears are open and they're listening and they're wanting to help. Or they may say, this is something that I know a little bit about. Let me do a little research and see what our options are. Those are the types of responses you're looking for. Red
Absolutely.
flags. Would you like to share some red flags?
Yeah, a red flag would be somebody that completely dismisses you, completely says there's no way you could be going through that because you're way too young, or, maybe this is just your stress that you're having. And, I don't think that you're having any of these. Anyone that doesn't validate your concerns and dismisses you, I think, is a red flag. And also somebody that gets very defensive, right? Instead of being humble and acknowledging that perhaps you don't know, just saying that, what, maybe instead, I'll refer you to somebody like you just said that does know. If somebody gets upset at you, angry at you, and starts to become defensive, then I think that's another red flag. And then, you should just find another practitioner, because there are so many. So, you shouldn't have to deal with somebody not believing you and dismissing you. And like you said, gaslighting you into thinking that you're crazy.
Yeah, absolutely. And I think it's probably useful, especially for women who are, I'm gonna go ahead and put myself out there, women who are around the age like me, who are
Right.
in that range of perimenopause and maybe experiencing that, is when you begin to, if you already don't have a practitioner who specializes in that or who knows or has knowledge about that, then to look for someone who specifically
Yeah.
call around, because you can ask, hey, this is what I'm going through. Does anyone in your practice specialize in menopausal care? Look for a physician who particularly like is specialized in that, but maybe is someone who is a person of color who
Yeah.
has a little bit different of a purview. That's not to say that, white OBGYNs do not have that level of compassion, but we do know that like people tend to like people. Like there's a
Absolutely.
instant sort of understanding and connection, and there are things that don't have to be explained sometimes
Yes.
when you're seeing a person who can share a lived experience.
Absolutely.
And so I think that's useful as well. See, these are just little things. And if you prefer, even if you prefer a male gynecologist, my dad is a retired OBGYN. So, he was loved by his community. Make sure that whoever that person is, that they're specialized in. And so that they have an empathetic understanding, even if they don't have a lived experience understanding, to have an empathetic understanding of what you could be dealing with.
100%, 100%. I think that's all that most people want, right? They just want a person, a doctor, a practitioner, whoever, just
Yeah.
to listen to them, right? And even if you don't have to have all the answers, but they just want somebody that is willing to validate them and to listen, and not just hear, but actually listen to what they have to say, so that they can, in the best possible way, help them out. And if they can't, then refer them to somebody that can help them, and just be humble enough to realize that, I don't know the answer, but I can refer you to somebody that does. And
Yeah.
here is their contact information and whatever. So I think that, really just finding a person that you can connect with. And like you said, I think that, it's always helpful if you can find somebody that maybe has your same lived experience. And if you can't, then trying to find somebody that may be the next best thing, I guess, or
Mhm.
because it's just that much harder when you have to explain everything, right? When
Yeah.
you have to explain the trauma over and over again, when you have to
Yeah.
explain, what the baggage you're carrying around, and it just takes that much more energy out of you. So if you can find somebody that has that same lived experience, it just helps.
Yeah, absolutely. Absolutely.
Yeah.
Well, this has been such a great conversation. I so appreciate you coming on. And because I think that there are things that are not as much talked about, especially when it comes to the impact of disparities in women's health. And menopause is one of those things.
Yes.
And I think, once you get of a certain age, then, it's like eased on out of importance. And so that's the ageism in our society. That's the
Absolutely.
ageism in our society. And so,
Absolutely. I
yeah, so I think that what you're doing is so, so useful and needed. And I appreciate you for the work that you do. And I want you to share with the audience, like how, if they're in the NYC, if they're in the New York area, how they can get in touch with you. If you have a podcast, I want you to share about
I
that.
do.
Share
Absolutely.
like how they can follow you and keep up with what you're up to.
Well, thank you so much. If I could just leave your audience with one pearl,
Yes.
I would love to do that. And that is that even if you decide, let's say that you're in perimenopause, you're in menopause, and you decide that you don't want to do hormones, nobody's forcing you to do hormones, you don't have to do hormones. But one thing that I would suggest that everyone do forever is take and use vaginal estrogen. Vaginal estrogen is so, so important, and it helps with the vagina and the vulvar health. And I know we didn't really get into that a little bit, but it's really important. And it's important for you to understand that, sexual pain is not normal. And so you should not be having pain with sex. And if you do, to make sure you go and get treated, and that you go and get evaluated so that you can get the hormone or the therapy that you need. The gold standard for vaginal dryness in menopause is vaginal estrogen, because it helps to not only increase lubrication, but it increases blood flow. It thickens up that tissue, prevents tearing, prevents recurrent UTIs, does all of that. And really, it's so, so important. So even if you decide you want to do nothing else, make sure you do vaginal estrogen. So I do want to leave you with that pearl. And if you want to come and work with me, I'm opening up, I should have actually at this point, by the time the podcast is released, have an office in New York. And so make sure you follow me on Dr. Sadaf OBGYN on Instagram and TikTok, and you can see where the office is. You can also reach out to me at drsadaf.com. You can also visit my website at drsadaf.com. That's drsadaf.com. I also have a podcast called the Muslim Sex Podcast, which I'd love for you to take a listen to. Dr. Claiborne was on there as well. So I'd love for you to take a listen to that episode. And I also want to invite people to my retreat. I'm hosting a retreat in Morocco, September 16th through the 23rd. Dr. Claiborne, you should come. We're going to be focused on menopause, sexual health, and nutrition as we age. And we'll also be taking excursions into Morocco, staying at one of the country clubs, and we'll be doing a barbecue on the beach. There's going to be hammams, daily meditation, yoga, spa, all of that, and a community of women that you can share your experiences with. So super excited about all of that.
That sounds amazing. Let me check my calendar.
Yes, please. We'd love to have you.
Yes. Well,
So,
thank you again so much. And thank you for that pearl. That was like, that was it. That was it. That was drop the mic. So
yeah.
thank you for that, Pearl. We
Yeah.
will have all of your information in the show notes. If you see us on YouTube, we'll have it in the description. Although now YouTube has a podcast. They have like an actual podcast section. So that's
Oh,
yeah, yeah. I just found out about that. I think that was very recent. So you'll see all of the show notes. And I want you all to not only to take this and incorporate it, into your own practices when you go into, whether you're a physician, if you're a physician listening to this, then look, you got to take this, and you definitely have to open your listening filters and make sure that you are listening wholly
that's
to
right.
your patients. And not saying that you're not, just, we all have things to continually learn and expand and grow. And if you're a patient, take some of the language that we've talked about, take some of the information. And if you are a woman who is entering that arena of perimenopause, or if you know someone who is, if your mother is, then you pass this podcast on to them, to a friend,
Please.
a colleague, a family member, because this is the stuff that makes the difference.
Absolutely. Absolutely. And thank you so much for all that you're doing, Dr. Claiborne, and bringing all this information to your audience. I think it only goes to help grow everybody's knowledge and helps them to advocate for themselves. So thank you so much for all that you do. You bring so much value. Thank you.
Thank you so much. Thank you so much. Well, you all know how to get in touch with me. If you need me, I am your belief and communication expert. So I do all things belief, behavior, and communication. If you want to have me speak at your organization, or if you want to learn more about how to communicate in a way that transforms, and we talked a little bit, just a tiny bit about communication, I have a course. And now I have a course that is CME accredited. So if you're a physician, you look at the podcast and you're like, I need some CME, and you've got some CME money, guess what? You need to be taking this communication that transforms, because you can get up to 22 CME credits. That's half your year of CME that you need.
Amazing.
So make sure you check that out at mindremappingacademy.com. And until the next time we meet again, stay empowered.
Thank you for joining me on today's episode. We truly appreciate our listeners, because without you, there is no podcast. I really hope you enjoyed today's episode and that it gave you fresh insights and practical tools to elevate your communication and build trust and safety in all areas of your life, from leading your teams to strengthening your relationships at home. If today's conversation resonated with you, please take a moment to subscribe to the podcast, share this episode, and leave us a 5-star review. Your support helps us reach more people looking to enhance their relationships, their leadership, and the communication in every area of their life. If you are ready to take your communication to the next level, I encourage you to check out our Communication That Transforms online course. This course dives deep into creating psychological safety, mastering trauma-informed communication that allows you to build behavioral flexibility and tackle any circumstance in your life. You'll learn practical strategies for handling difficult conversations, navigating conflict, and cultivating trust in a way that truly resonates with the people around you and leaves them feeling seen, heard, respected, valued, and welcome. This course is designed to help you transform not only how you lead, but how you show up in all your relationships, whether in the boardroom with your teams or at home with your family. Check out the course at mindremappingacademy.com/TICC to learn more, see the full course catalog, and register. This link will also be in the show notes. That's www.mindremappingacademy.com/TICC. Finally, if these topics resonate with you and you want to bring them to your department, your team, or your organization, I'd love to speak with you. Reach out to me and invite me in for a workshop or a conference tailored to elevate your organization's trust, collaboration, communication, safety, and belonging. You can learn more and reach out to me by visiting mindremappingacademy.com/corporate-programs. Remember, change happens one intentional conversation at a time. With one small shift in how we connect, listen, and lead. Keep listening with intention and communicating with clarity. And until the next episode, stay empowered.